Hi, folks. We're going to give it a moment before we officially start, but glad you are with us today. As we wait for folks to join, would love for you to introduce yourselves in the chat. It's always nice to hear where folks are coming from, your roles, organizations. That would be fantastic. And I know that this recorded session will be a great resource as well. So I want to acknowledge those who will view the recording at a later point. So as we're waiting, just want to say again, hello and welcome. This webinar is going to be focused on navigating polypharmacy management in older adults. And yes, welcome. Feel free to click on in your drop-down box in the chat, send to everyone, any information you'd like to share. Love to see where folks are coming from. We'll do a little Mentimeter exercise as well to visualize that. All right, so I know we'll have more folks come on as we go forward, but wanting to move forward for the sake of time. So again, today's webinar is going to be focused on navigating polypharmacy management in older adults. Our center is the National Center for Equitable Care for Elders. My name is Arielle Mather, and I'm the program manager of our center, and really excited to be able to have a couple of fantastic panelists with us today. Some quick Zoom reminders. Because this is a webinar, everyone is muted, videos are off, all of that. Just the panelists you'll see and can hear, but we'd love to hear from you in the chat, in the Q&A box. All questions, comments, feedback, it's great to hear from you. So as our speakers are presenting information, feel free to ask questions and engage. Like I mentioned, this session is recorded. It'll be a great resource for folks, especially those who signed up and can't attend live. We will be sending out a PDF of the slide deck as well as a resource. And as always, we love to hear your feedback. So a Zoom poll will pop up when you exit the session. We would encourage you to take just a moment to share your feedback, which helps inform future training and technical assistance activities. Thanks to those who are introducing themselves in the chat. So if you are not familiar with our center, we are a HRSA-funded national training and technical assistance provider. So we are focused on providing learning activities and resources to health centers across the country. We'd love for you to stay connected with us. You can see a bunch of links here. Those will all be active links in the PDF that you receive of the slides. Would love for you to check out other learning opportunities we have coming up, which we actually have a slide for that. A couple of activities that are happening very soon that if you haven't already heard about them, would encourage you to check out. One is a learning collaborative, which means it's a series of sessions that we're going to be focusing on this spring on leveraging local strengths to improve older adult health and well-being. So if you want to join us every Tuesday from the beginning of April to mid-May, we're going to be talking about models of collaboration between health centers and healthcare providers with local area agencies on aging and other community-based organizations to reduce health disparities in older patients. So we'd love for you to sign up for that. And then we also have a webinar in mid-April focused on addressing substance use disorder in older adults, going to be focusing on principles of care, really diving in with an expert on how to early identification, recovery management in this population. So we'll include links in the chat for that if you want to take a look on our site and sign up. Otherwise, you may see it in a future mailing. That'd be great. All right, let's go to the next slide. Great, wonderful. So today's learning objectives, as you saw when you signed up for this session, we are going to be thinking about this topic in the context of the 4 M's of an age-friendly health system. In that framework specifically, so considering medication and its role there, we're going to have some really good content around health literacy and how it's so important for managing these complex medication regimens, and then hopefully sharing some helpful strategies around effective deprescribing and improving medication adherence in your older patients. So we'll go ahead and hear a little bit from you before we hear from our wonderful speakers. If you're not already familiar with Mentimeter, you can use your phone and grab the QR code on the screen. You can go to menti.com and put in the code 4667-4590. This is a fun platform that just easily lets us all visually see our responses. We'll just get to know a little bit of where folks are coming from and kind of what you were hoping to get out of the session today. So I see some thumbs up in the corner. I'll say that if you're having any issues accessing Mentimeter on the site itself, feel free to put your responses in the chat box instead. So we'll go ahead to our first question. Is just a map. So if you want to pull a little dot for yourself or just point on the map to where you're located, that should pop up as we get more folks responding on there. So we'll give it a second. See a couple dots. I know in our panel group today, very strong East Coast representation, and I see good New England representation in our audience. And there we go with the West Coast as well. Again, if Mentimeter is not working for you, feel free to put it in the chat. All right, great. Perfect. Thanks so much for sharing. Go to California. Thank you so much. All right, awesome. All right, so you all signed up for this session on polypharmacy. So wanting to know your thoughts, it doesn't have to, there's no wrong answer here, but what comes to mind for you when you're thinking about polypharmacy specifically for older adults? How does that impact them? This is going to turn into a word cloud, so it's good to have 1 to 2 to 3 words. Great, thank you. Oh, thank you, Northern California. Safety, expensive, medication interactions, confusion. Thank you in the chat as well. Falls, so everything will get bigger as more responses come in for that. Scared, yeah. Not effective. Safety, interactions, yeah, for sure. We see a couple of word cloud items that fall under that category. Great, yeah. Thank you so much for those responses. It's clear that we have some common ideas here on how this impacts this population. Let's go ahead to our last little question for the group before we transition to our speakers. We do ask this in our registration, but I think it's really nice for everyone to see what you hope to take away from this webinar. Sometimes it's as simple as just more knowledge or resources to share, but it'd be great to get a sense of what folks are hoping to walk away with today. This is more of an open-ended, so feel free to use more than a couple of words. Whatever works for you. You can also put it in the chat. There's no wrong answer here too. Knowledge and keeping patients safe, absolutely. Effective techniques, yeah. Ooh, to convince providers, yeah, that's certainly, hopefully we'll be able to get some perspective from our panelists on that as far as the conversations you're having with your colleagues on an interprofessional care team, educating patients, knowledgeable, wonderful. Great. Yeah, fantastic. These are all wonderful goals that hopefully align well with the content we're going to dive into momentarily. Great. Oh, yes. Wonderful. Thanks so much, everyone, for sharing. That's fantastic. So we are going to transition now to introducing our panelists. And thank you to those who are giving answers in the chat. Fantastic. I'm going to give the briefest bios to just kind of acknowledge how much wonderful experience and insight our panelists have, and I will then let them give any more context about their background and what's brought them to the point where they are today. So I'll start with Andrea Schwartz, who is the co-director of the Aging and End of Life theme at Harvard Medical School and is a national leader in the Age-Friendly Health Systems Initiative. Dr. Schwartz is the Associate Director for Clinical Innovation in the New England Geriatrics Research Education and Clinical Center at VA Boston, and is also the Associate Director of the Harvard Multi-Campus Geriatrics Fellowship. We're also joined by Stephanie Taylor, who is a registered pharmacist, a consultant pharmacist, and a doctor of pharmacy. She joined the Florida Community Health Centers in 2019 as an outpatient clinical pharmacist and now oversees pharmacy operations. She uses her talents for problem solving to address gaps in processes and procedures that impede successful delivery and execution. And I know, Stephanie, in your longer bio, you were nominated by your local council on aging several years ago about your work in a chain pharmacy. So I'd love to hear more about that when we get to your presentation. I just want to say again how honored we are to have these two experts with us today. We're going to go into presented content, but encourage you all to put in questions and comments in the chat and the Q&A feature at any time. So I will hand it over to Dr. Schwartz.
Thank you so much, Ariel, for that wonderful introduction, and delighted to be with you all today. So as Ariel said, I'm a geriatrician based in Boston at Harvard Medical School, and I'm really delighted to speak with you today about some of the concerns you all put in the chat of ways we can navigate polypharmacy in older adults. And then I'll be delighted to pass it on to Stephanie to talk about some of the practical implications, and so you'll get to hear her perspective as a pharmacist. So when we talk about safe medication management among older adults, what we really want is an age-friendly approach where medications are in the service of an older person doing more of what matters to them. And you can see here on this slide the 4Ms framework developed by the Institute for Healthcare Improvement as part of the Age-Friendly Health Systems Initiative. If you've seen this or seen the 4Ms before, you're welcome to use the reaction tool on your Zoom to give me a thumbs up. And Juliet just put in the chat more information about this overall initiative, which really aims to help health settings implement the 4Ms in every care setting where older adults are served. You can see that the 4Ms include a focus on mobility and falls risk reduction, mentation, so recognizing and mitigating risk of dementia, depression, and delirium, medications, as we'll be discussing today, and a focus on what matters, which is really being aware of an older person's goals, what matters to them, and making sure that their healthcare is helping them reach those goals. So we often talk about the 4Ms as a set. And while we zoom in today on the medications M, as we'll see, medications both affect and are affected by each M. As we already saw in the Mentimeter questions, medications can affect your mobility, say increasing your fall risk if they make you dizzy, and your mobility can affect your medications, your ability to get down the stairs and get to the pharmacy to pick up your medications. The same is true for mentation, where medications can help with your mood or make you confused, or your mental status could make it difficult for you to manage your meds if somebody has dementia and has a complicated medical regimen without assistance. And of course, medications ought to be in service of what matters and helping older people reach their goals. So I invite you to join me for a quick chat waterfall where you'll type in your answers, but don't hit enter until I count to 3. What's a word or two about what makes medication use so challenging in older adults? So go ahead and type in the chat, and then I'll count to 3 and you can all hit enter. What makes medication use so challenging in older adults? Just a word or two. 1, 2, 3. Go ahead and hit enter. Thank you, Gina and Ruby, for starting us off. I see some great answers coming in, really going from things that are innate to the aging body, like you're changing metabolism as you age, as well as social determinants of health, like language and affordability, as well as physical things like vision, cognition, openness to change, hand dexterity, there's that mobility. So excellent answers. And I think shows us what a complex topic this is. So we really need a really holistic approach to medication management. So if you look at the different answers that you all put in the chat, they fall into one of these buckets that I'm going to show. One is the low representation of older adults in research, which means that sometimes the meds that we prescribe have only been studied in younger, healthy people or people with one disease, not multiple chronic conditions. We've got health system factors that compound complexity, like having multiple prescribers, multiple pharmacies. And then we've got physiologic changes, as some of you have mentioned, that could affect a person's ability to read their pill bottles, open them, swallow them, manage their meds. And then we've got polypharmacy, just the sheer number of medications and the type that can get in the way of adherence. So there are so many different reasons why this topic is challenging. Fortunately, we have helpful approaches that can help us do this well for older adults. So when it comes to polypharmacy or multiple medications, potentially inappropriate medications, there's a saying that any new symptom in an older patient should be considered a possible drug side effect until proven otherwise. This is the idea that a new symptom like dizziness, falls, confusion, constipation could be a med side effect. And we ought to investigate that fully as we are looking for other causes. You'll see that Juliet put a link in the chat to a workshop that this workshop is based on, which is really thinking about how you can integrate this principle into the primary care setting. Now, in an age-friendly health system and with the age-friendly approach to medication management, there are several classes of medications that are considered potentially high risk that we want to avoid or minimize or make sure that we're using the safest possible alternative, including non-pharmacologic and pharmacologic alternatives. So you see some of the classes of medications here, and likely these are ones that you're very familiar with. They're very commonly prescribed classes of medications. And when we talk about an age-friendly approach, we really want to be assessing for these potentially inappropriate medications and looking for safer alternatives when possible. So how can we do that? I'm going to give us a few more background slides about polypharmacy, and then we'll get into a practical approach. So typically, when we think about the number of medications that it takes to get to polypharmacy, anyone want to put a number in the chat? How many meds do you think counts as polypharmacy? Some people say just one inappropriate med, but yes, most people say what Maricela and Gina put in the chat, which is 5 or greater than 5 medications. And as the number of meds go up, you see these adverse effects like disability, frailty, drug-drug interactions, impaired cognition, slow gait speed, falls. All of these, there's a dose-response relationship. The more meds you're on, the higher the risk. So when we try to adopt that age-friendly approach, and I'll put a link in the chat to an article that really helps us think about the 5 M's and the 4 M's in polypharmacy, along with the 5th M. Oh, I think Juliet beat me to it. Yes, exactly. So this is an article that really gives us the approach to think about meds in relationship to each of the M domains. Thank you, Juliet. And what we tried to do here is make it clear that you can't just focus on the med list. You've got to focus on the other M's as well. And that's what we're going to be doing in our workshop today. So someone already gave the example, I think it was Gina, of like, well, can your patient even open their pill bottle? If you've got a child safe cap, you may not have the hand dexterity to get it open. But if the older person you are working with lives alone and doesn't have children visiting their home, maybe a child safe cap is not the right thing for them. Maybe they need a Jerry cap, an easy open cap, a pill box, bubble packed. There are many options that might be better fits for them. So what we're going to do in my part of the session is a mini case. This is not based on a real patient, but you'll notice very familiar patterns that you may see in older adults that you care for or people that you love in your family. So this is Mr. V, and he's 86 years old. He is, I should have put on the slide, he is a retired, he is a veteran, and he's a retired professor. He has a very full life. He's a grandfather, a husband, he swims, he gardens, he's part of his religious community. He also has a lot of chronic conditions. This is only part of his medical problem list. And you can see he has conditions that are very common with aging, such as high blood pressure, high cholesterol, diabetes, arthritis, prostate, enlarged prostate, atrial fibrillation, a heart condition, and insomnia. So with this medication, with this medical list, we're going to think about what kind of a med list we might expect Mr. V to have and how we can think about optimizing it, which will involve some deprescribing. Now you can see the definition of deprescribing here, which is the planned or supervised process of dose reduction or stopping medications that may be causing harm or no longer providing benefit. When we talk about optimizing medications in older adults, sometimes we need to add medications that are missing, inadequate pain control, or not taking the meds that can help minimize complications from disease. But sometimes people end up on these potentially inappropriate meds that can cause more harm than good and get in the way of doing what matters. So I'm going to go over a 5-step approach to deprescribing. This was developed by Dr. Ian Scott and published in JAMA about a decade ago. And it's really stood the test of time as a very practical approach to deprescribing and optimizing medications. I should note that this approach was adapted from the Geriatric 5Ms for Primary Care workshop that Juliet posted in the chat, which has been adapted for many different care settings to try to help us all improve care for older adults using this age-friendly approach. So on this slide, you can now see Mr. V's medication list. So first, just take a moment and look at how many medications he is on. The very first step in deprescribing is figuring out what is the person already taking. And that sounds simple enough, but as Stephanie will discuss, when you actually ask the person to do a brown bag medication reconciliation, bring in all of their medications, we often will find duplicates, missing meds, expired meds, or even other people's meds. So we want to be really careful and make sure we have a complete medication list. So that's the very first step, is what is he actually taking? The next step is to reorganize this med list. We have it here, the alphabetical, but a much safer way to organize a med list is either by times of administration, so AM and PM or 3 times a day, or by indication. Why is he taking these medications? So based on the problem list we showed you, we've reorganized the med list so we can see all the blood pressure meds together, the atrial fibrillation medications, the cholesterol medication, diabetes, anxiety, insomnia, and that leaves us with a few medications for which we don't have a clear indication. We need to know which pain Mr. V is using the Tylenol and the naproxen for. And is he having heartburn for which he's taking omeprazole? Is he having constipation? Or are those meds that have kind of been carried forward that he may not need anymore? So that's all step one, just figuring out what he's taking and which ones may not necessarily be necessary. The second step is to consider the risks and benefits of use. And there are many tools out there for this. 2 that I'd like to mention are the American Geriatric Society Beers criteria. This is a list developed by experts led by pharmacists and geriatricians that is updated every 3 to 4 years. And it includes both a list by category and by disease, by type of med and by indication that can help clinicians think about which are high risk or potentially inappropriate medications that ought to be avoided. Another helpful tool is the anticholinergic risk scale. This collates medications that may cause dizziness, confusion, falls, and can help the prescriber think about which ones to potentially avoid. So now let me ask you, looking at this med list, which medications might you be worried about? Which ones might you think about deprescribing or asking Mr. V's prescriber to eliminate? You can go ahead and type in the chat, which medications would you want to focus on? And I'll give you a moment to do that. Any takers? And if you're not familiar with the categories of medication, that's okay. We're going to be going over some of them together. Great. So I see Alex noted the blood pressure meds. Right. So Mr. V is on 3 different meds for blood pressure. So as we age, that could lead to dizziness. It could lead to orthostatic hypotension, where your blood pressure falls when you go from sitting to standing. We really want to know what's his blood pressure and is he being overly tightly controlled. Plus, that hydrochlorothiazide, it's a diuretic. It makes you pee. We don't want him rushing to the bathroom in the middle of the night. So that's a great one to start with. Ruby pointed out the Docusate, which is a stool softener, but it's been shown to not be very effective. So it might just be cluttering up the med list. And then Gina, you pointed out the omeprazole. Does he have reflux? Does he have some other indication to be on it? And then Jessica, you've got a lot in yours that are hit the nail on the head. Alprazolam, that's a benzodiazepine that is used for anxiety. But as we age, those meds hang around our systems longer And because of the changes in our physiology with our kidney and our liver, those medications have the potential to cause confusion, cognitive impairment, and falls. And then naproxen, ibuprofen, those are both NSAIDs. They're non-steroidal anti-inflammatories, which means they're painkillers, but they both can cause bleeding, especially in someone who's on apixaban. Now, at first pass, you wouldn't necessarily get into all this detail, but I'm a geriatrician, and this is our bread and butter. We're trying to tease out, what do we do with this kind of a med list? Where should we even start? So we're on step 2 now. We figured out what he's taking. We're thinking about which meds might be particularly risky. Jessica just pointed out glyburide, which is an older diabetes med that has many side effects. It's cleared by the kidneys, so it can hang around for longer and cause hypoglycemia or low blood sugar. So that's a great one that we could maybe get rid of. And diphenhydramine, thank you, Sarah. That's Benadryl. You can buy it over the counter, and it is one of the most dangerous meds for older adults because even one dose can lead to confusion, falls, and so that's another one that we really want to know if we can get rid of that. So we've got our work cut out for us. And what I want to show you next is where to start. So I think you've named all the ones that I flagged. And we could keep going because for almost every med on the list, we really need to ask, is it still necessary? But when we think about where to start, one of the things that we're trying to focus on is there a potential or active adverse reaction? So if Mr. V were coming in because of falls, I might prioritize, say, the Benadryl, the alprazolam. If you were coming in because of hypoglycemia and low blood sugar, I'd obviously prioritize the glyburide. If you were coming in because of dizziness, I might prioritize the blood pressure med. So that helps you get a sense of where to start. Then there's the low-hanging fruit. If there's no indication or it's not working. And then there's the prescribing cascades. This refers to a med that is added to treat the side effect or another med. So for example, let's say he came in with incontinence, but instead of looking at that hydrochlorothiazide, which is a blood pressure med that can lead to excess urination and can lead to incontinence, instead of looking at that hydrochlorothiazide and maybe deprescribing it, decreasing it, let's say he gets added a new medication for urination. That would be a prescribing cascade. So that's something to always be on the lookout for. Or if, let's say he'd been on iron, well, that can cause constipation. Does he still need the iron before we keep titrating up the constipation meds? And then we also think about the treatment burden, meds that are multiple times per day or that the patient feels are burdensome. Those are good candidates to think about potentially deprescribing. And then there are the meds for which there are obvious safer alternatives. Jessica pointed out glyburide. We could switch to a different class of meds altogether that might be much safer and avoid the risk of hypoglycemia. On top of that, we really need to think for an 86-year-old with multimorbidity, what is an appropriate blood pressure goal? What is appropriate diabetes goal as reflected in the A1C? It might be higher than it would have been 10 years ago. And so we really need to adjust the medications to meet those appropriate goals. Step 4, we need to prioritize the different medications we might deprescribe. We already discussed benefit versus harm. The ones that are clearly causing harm with no benefit should be a first move. But we also want to prioritize ones that are easiest to discontinue, ones where we don't anticipate having a side effect. Glyburide is a good example of that. We don't anticipate there be any side effects, and you can just stop them. You don't need to taper them. We also want patient buy-in. So let's say alprazolam, that benzodiazepine that might be causing confusion or falls, if he's been on it for 20 years, that's probably not the first one that we are going to try to deprescribe. We want to build trust. We want to get patient buy-in. We want to understand his goals and what matters to him and make sure that the medications he's on are helping him reach those goals. If it's primarily to treat insomnia, well, there are safer medications for insomnia, as well as non-pharmacologic approaches, such as cognitive behavioral therapy, that can be as effective or even more effective than medications. So there are often many things we can do to both simplify regimens, to partner with patients around shared decision-making. And then, of course, there's cost. That is often a reason why patients are interested in deprescribing and a benefit they may find from removing a med that is no longer giving them benefit. 2 tools I like to recommend for deprescribing our med stopper, which allows you to put in a med list and it'll show you this med's on the beers list, this med needs to be tapered. Or for specific medications, deprescribing.org from a Canadian group has algorithms for those of you who are prescribers to help you taper, say, an omeprazole or proton pump inhibitor without having rebound heartburn symptoms, or taper a benzodiazepine safely without risking withdrawal seizures. So medications do need to be stopped with the same thoughtfulness as starting them. And I like to say that all of us are responsible for the larger goal of optimizing medications in the service of what matters. And that's because even if many of you on the call may not be prescribers, you can notice high-risk medications, you can notice a complex med regimen, you can notice a patient who is experiencing pill burden or polypharmacy, and you can flag that for the primary care clinician or for the prescriber and help make sure that the patient is having a conversation about how to optimize their medication list to make it age-friendly and as safe as possible. When we talk about stage 5 of the deprescribing protocol, one of the key things I like to remind people is to give written instructions. This sounds obvious, but sometimes the med list that gets automatically printed at the end of a visit may not reflect some of the changes in a way that will be easy for the patient. That might mean taking an extra step, collaborating with the pharmacist or nurse on the team to create a grid of which pills to take in which part of the day that'll match the pill box, actually getting an alarmed pill box, or teaching the care partner how to pack the pill box so the patient can't do it themselves. But involving the patient and family or loved ones is critical in this step. Additionally, whenever changes are made to a medication list, planning a follow-up, whatever setting you're working in, so that you can monitor for any adverse drug withdrawal events, as well as any symptoms that might lead you to restart the medication or move to a different one or to a different backup plan. So knowing how you're going to monitor the success of this change can help to have a smooth, trust-building experience when optimizing a patient's medication list. So again, stopping a medication should be done with the same considerations as starting one, and we have tools that can help us carefully deprescribe and optimize medications lists for older patients. So going back to Mr. V, what are some recommendations you might have based on what we talked about? And you can scroll back up in the chat as a reminder of some of the meds that he is on. So I'll give you a moment to type into the chat, what is a medication that you might want to deprescribe or change or find a safer alternative for Mr. V? Okay, and you can go ahead and enter your responses. Well, I'm not seeing any responses yet. I'll share some to get you started. So an easy one might be to stop the diphenhydramine, the Benadryl. As we said, that could be leading to confusion, and there are safer alternatives if he's taking it for sleep or for itching. Same thing with alprazolam. That's one that needs to be tapered. So we would use the tapering algorithm from deprescribing.org and partner with pharmacy or nursing colleagues to monitor his taper and see if he may need another medication such as an SSRI therapy, cognitive behavioral therapy, or other treatments to manage his mood or insomnia or anxiety. Same thing with the omeprazole. That can be tapered and Tums can be taken as needed. The glyburide could be stopped for his diabetes. And then we would check to see if he's having any symptoms from orthostatic hypotension, blood pressure dropping when he goes from sitting to standing. Now, we wouldn't necessarily do this all at one visit. We might just start with one thing and monitor and build trust. But the goal is whenever we review a medication list to look for opportunities to make it safer, make it age-friendly, and make sure that it's in service of helping our patients do more of what matters to them. So with that, I'll take any questions that you have on my part of the presentation, and I'm super excited to pass the baton to Stephanie, who will bring her perspective as a pharmacist on how some of these concepts practically play out in the clinical setting. Thank you very much.
Amazing. Thank you so much, Dr. Schwartz. We will, as Juliet gets the screen ready, certainly if there are questions that are coming up as you're reflecting on some of this information, feel free to put that in the chat, in the Q&A feature. We'll be able to start responding, and then we'll have some dedicated time for conversation at the end of the talk. Great. Well, I'm going to hand it over to Stephanie. Very excited for your presentation.
Great, thank you. And good afternoon, everyone. It's such an honor to be on the same platform as Dr. Schwartz. Wasn't that presentation just fantastic? I'm hoping that I can add a little bit of my perspective to your approach to managing polypharmacy in your particular service areas, wherever you all are hailing from. Just a little bit of background information about me. I am in fact, a clinical pharmacist who has since changed to an administrative role. I work in a federally qualified health center where we service patients who, quite frankly, across the spectrum, see our practice physicians for both pediatric care, and they see our doctors here for primary care. And what's new and emerging in our practice environment is the care of older adults. And so I am working in concert with other individuals at my organization now to make sure that our health center is prepared to service older adults. And I'm bringing a lot of the pearls that I brought from community pharmacy into our current practice site. So I'm hoping that together, you and I can share information that I can even take moving forward to embed in our practice site here. But I'm very pleased and honored to have a few minutes of your time. As for Council on Aging, I had the pleasure of working with quite a few patients that visited our local Council on Aging center and was able to basically gain their trust and talk to them about their polypharmacy. I was able to come in and do their clinical vaccinations. I was able to be a resource for a lot of the patients at our local pharmacy for older adults visiting the Council on Aging who had medication-related issues or problems or therapies that they would like to get some perspective on from the pharmacy standpoint. So they would come over and they would see me. And as a result of that relationship, Council on Aging said they voted me like best practice pharmacist in the community at the time. So that's how I got that honor. So without further ado, thank you. Thank you, everybody. Can you advance to the next slide, please, Ariel? So Dr. Schwartz mentioned the brown bag. And I thought I'd put this picture up here in front of you guys because I'm sure many of you can relate to seeing just bottles and bottles of medication being presented to you, whether it's in your doctor's offices or in your particular clinical practice site. You've seen your patients come in with just numerous or copious amounts of prescriptions, and it makes you scratch your head and try to understand, oh my gosh, what is going on with this particular patient? Why are they on so many medications? And quite frankly, it kind of boggles my mind. I would say to myself, I don't think I could ever be one of those patients that are on 10, 15 medications each day. And here we are. We're dealing with a lot of patients who are on 10 and 15 prescription medications each day. Can you advance to the next slide? So we know that polypharmacy is likely to occur when a patient is seeing multiple care providers, they're going to multiple pharmacies, and then there's an overall lack of communication amongst providers or clinicians or those who are involved in a patient's care. They're not able to speak and talk to one another and discuss the treatment plan for the patient. And so what happens is patients go home and they have, like Dr. Schwartz mentioned, bottles of medication that are usually therapeutic duplications, medications that are expired or they're no longer taking or have been discontinued, but they still end up in their home or on their medicine cabinets or in their kitchens. And so when they come in for those brown bag days, or when they come in to see their clinician with all their medication bottles, they're left with copious amounts of drugs that we have to kind of filter through and do a reconciliation on. Next slide. So I'm posing a question to the group. The question is going to be a poll. if you can just take this poll and answer, how many medications do you think are prescribed to the average adult between the ages of 50 and 64 out of the choices that you see on the slide in front of you? And I'm not trying to trick you, but how many are prescribed? That's different than how many prescriptions patients are taking. How many do you think are prescribed? Okay. I'm gonna see if there's anything in the chat. And all right, let's see. Okay, so there are about 11% of you who selected 5, 44% of you, most of you selected 7, 33% 10, and then 11% 13. So the answer to that question is actually 13. There are about 13 prescriptions that are prescribed to that particular age group. Medications prescribed, not necessarily that are taken, but 13. And as a person's age increases to over age of 80, that number increases to 22. So can you imagine a patient if they were prescribed 22 medications and they actually took all 22? Now, as a pharmacist, I cannot recall where a patient gets every prescription that the doctor writes for them. That just does not happen. It doesn't. It could be any number of reasons, but can you imagine being prescribed 22 medications over the span of your lifetime if you're 80 or older? That is a lot of prescriptions. So if you wouldn't mind advancing to the next slide. What's not represented on this slide in front of you is the fact that about 4.6 or 5 prescriptions are taken by patients who are Medicare eligible each day. And so most Medicare eligible patients, those are patients over 65 years of age, they are taking at least 5 prescriptions, and they are probably a great candidate for polypharmacy. A recent study in the Journals of Gerontology found that 21% of people over that age of 65, they're able to receive a comprehensive medication review, but they don't know about it. 83% of them are unaware of the fact that they're able to receive a comprehensive medication review. And this is a service that is free if you have Medicare Part D. And can you imagine how many folks, if they were able to take advantage of that free service, would probably be able to reduce their medications or find some medication-related problems that would just keep them out of the hospital and have some unnecessary complications from overused or underused medication therapy. This is particularly evidenced by patients who are low income, and patients who are elderly would definitely benefit from this particular service. Next slide, please. So what happens as a result of polypharmacy, as Dr. Schwartz mentioned? There are therapeutic duplications, drug-drug interactions, adverse drug reactions, non-adherence to therapy, increased risk for falls, and an increased functional decline. So I put the slide here because I really am a pharmacist advocate. I really believe that pharmacists are in a great position to serve an unmet gap in patients' care. We have the clinical knowledge, we have the accessibility, and we have the understanding and trust of the patients that we care for in our practice sites to be able to be that go-between between a clinician, other ancillary staff, and our patients. And I do think that the pharmacists may be underutilized in a lot of ways when it comes to reducing polypharmacy. So I was really pleased at being given the opportunity to have a platform today so that I can advocate for my profession. But I really do believe that pharmacists are in a great position to help clear up some of these problems and reduce some of these unnecessary risks to our patients, especially our older adult populations as it pertains to polypharmacy. Next slide. So I just wanted to briefly just show you how pharmacy care practice has evolved. In the early 1900s, pharmacists were considered artisans of the trade. They would compound or make medications and to treat common illnesses. And it wasn't until the 1950s when manufacturers started to produce medications and drugs on a larger scale that pharmacists were kind of quarantined off to dispensing and doing simple compounding. And so they kind of lost the artisan skills that they once had around the 1950s. But it was a good thing for the profession because it allowed us to pivot. And that pivot took place in the early 1960s, where pharmacists became more embedded into the clinical practice sites on patient care units, particularly in hospitals. And the concept of clinical pharmacy evolved in that particular time period. So fast forward to 1990s, a lot of the schools of pharmacy have pharmacists that are focused on providing drug therapies and achieving outcomes that improve the patient's quality of life. And today, a lot of us are embedded in the community pharmacy practice. We're doing specialized disease therapy management and just expanding on our scope of skills to include clinical practices in all different environments. Next slide, please. So I put my perspective, because it is just my perspective as a pharmacist, but my approach to polypharmacy when I first became licensed as a pharmacy professional in the 90s, it was to engage with the patient one-on-one at the patient when the patient presented at the pharmacy with the prescription. And that initial engagement was basically an interview where I would meet that patient. We would discuss medications that they're currently taking. We would discuss their preferences, how they preferred to have their medications delivered to them, whether or not they preferred easy caps or child-proof caps, if they had their allergies, any contraindications that needed to be noted in their drug record. This was oftentimes done on the initial first dispensing from a pharmacy. And then I'll be quite honest with you, over time, this particular interaction becomes fewer and fewer in a retail pharmacy setting, because there's just so much other engaging activities that pharmacists are doing that they don't get to spend that one-on-one time with the patient when they first enter the pharmacy. They usually get that one-on-one time at the end of the transaction when the patient is picking up a prescription, and that's the consultation. But these are the times where a pharmacist could do an assessment of any drug therapy problems that the patient may have. We also act as a conduit between the doctor or the clinician and the patient. So if there was any drug therapy issues that we encountered as we're dispensing the patient's medication, we will open up that dialogue between the two and just make sure that we were there to help mitigate any errors or any issues related to their drug therapy at that time. Now, a lot of that has not changed as it pertains to the community pharmacy. We still do the interview and the consultation with the patient. We still act as a conduit between the patient and the clinician to troubleshoot or resolve drug therapy problems, But if your care setting allows for it, pharmacists are also able to have a more intensive one-on-one conversation with the patient, where they're able to do medication therapy reviews with the patient and use that as an opportunity to discuss whether or not their medications are being optimized, or whether or not there's some deprescribing that should be suggested with their clinician. And so I'm starting to see, if we haven't already, in different practice settings where pharmacists are getting more and more involved in the clinical practice activities as it relates to polypharmacy. Currently, we use platforms like Outcomes MTM. I'm not sure if any of you are familiar with that, but it's a population health-based platform that identifies opportunities for Medicare, for the pharmacist to identify Medicare patients that are not getting optimized treatment or optimized therapy for their medications. And so we're able to target those patients and work with their insurers and their clinicians to make sure that those patients' drug therapy is being optimized. We also have access to electronic health records, particularly at the Federal Qualified Health Center where I work. It's a wonderful atmosphere because we are able to work collaboratively with the team and with our clinicians to help resolve issues with the patient's care. Next slide, please. So you may wonder, when is there an opportunity especially in a busy pharmacy, when is there an opportunity to screen for medication, appropriate medication use? And as I mentioned before, it's during the patient consultation. You can go ahead and advance the slide. It's during the drug utilization review, and it's during a medication therapy management review. And the goal of a patient consultation is to simply, as it pertains to the older patient, is to making sure that we're using shared decision-making and communicating with the patient using health literacy. And some of those tools of health literacy with an older adult, communicating with an older adult, is to first and foremost use plain language when you're speaking with an older adult, or anyone for that matter, in the pharmacy. Medications are, to say the least, they can be very complicated. Medication treatment can be very complicated, and simply understanding the instructions for use can be very difficult for the most astute persons, especially if we're talking about the care of chronic diseases and management of chronic diseases. So if you're just using plain language, you're minding your diction and the tone in which you speak, looking for verbal or nonverbal cues of a patient's ability to understand what you're communicating to them. At times, we have to use visual aids to communicate with the patients, with the older patients, if necessary. Making eye contact, always asking for permission to speak with someone who may be accompanying the patient for a translation or to add clarity to a conversation that you're having with the patient. These are all ways in which we try to use shared decision-making and promote good medication literacy with the patient when we're assisting them in the pharmacy. Next slide. So this is a lot, but basically utilization review is the opportunity for the pharmacist to pretty much use the tools in their pharmacy dispensing software to identify a lot of these therapeutic drug interactions or therapeutic duplications in therapy, or it will identify for us an over or underutilization of a medication that's prescribed. Utilization review can be done before a drug is dispensed. It can be done during the treatment of a patient's therapy, and it can be done after a medication is dispensed. You can go to the next slide. And thank you. We'll go ahead and skip to some pharmacy considerations for dealing with an older adult population. This might be a little bit busy. I'm looking at it now and I'm like, it's a lot on this slide. But first and foremost, you might want to consider whether or not there's any clinical gaps that require your pharmacy staff training to be prepared for an older adult. As Dr. Schwartz mentioned, you want to make sure that anyone dealing with older adults understand the Beers criteria drugs and how medications, how you have to be careful about prescribing medications that are not appropriate for the older adult. So it might require some training if the pharmacist or the pharmacy staff are unfamiliar with dealing with an older adult population. You want to make sure the pharmacy's physical environment of care is appropriate for an older adult. You want to make sure it's properly lit. If there's any guardrails that are physically present, if a patient should need access to those particular guardrails. You want to make sure that any trip or fall hazards have been assessed and that you've removed those triple fall hazards if you're dealing with an older adult population. You want to, number 3, look at safeguards and alerts to make sure that they're in place to recognize those Beers criteria drugs. Those safeguards and alerts are usually embedded within your pharmacy dispensing software, but there may be some other alerts that you can put in place, some physical, like tagging or color coding certain drugs within the pharmacy to indicate that those are Beers criteria drugs. You want to leverage screening tools to identify the appropriate medication use. You might want your pharmacist to approach medication adherence with health literacy in mind, as I mentioned before. This is particularly important because right now, at least in our particular care practice, we see a lot of patients who have cultural and language barriers. So we do use a language literacy line. We use translators. We also make sure that we hire personnel that speaks the language of the patients that we most often serve in our different pharmacies. So that's a very important consideration. And we also make sure we have visual aids available to assist with consultations and communicating with our patients. We want to make sure that all of our internal protocols that are established identify and provide comprehensive medication reviews. And then we want to make sure the pharmacists are using the shared decision models to recommend safety prescribing. Our pharmacists should be familiar with the appropriate tools, such as the stop-start tool, the deprescribing tools that Dr. Schwartz mentioned, and there's several other tools available. Thank you. Next slide. Hi, Ariel.
Hi.
And so I've listed a few resources here that might assist you if you are interested in learning more about how you might want to use or embed some of these resources in your particular practice sites to help manage polypharmacy in your older adult populations.
Wonderful.
And then I will turn it over to you.
Great.
Thank you.
So much. Yeah, this was fantastic. I know we had a couple questions come in. We have just a handful of minutes, so if you want to put anything else in the chat, the Q&A, please do. But I know that someone had a question around, I think for Stephanie, for this comprehensive med review, is this just a pharmacist? Can a nurse do this? My understanding is that there's several folks as long as they have certain qualifications, but can you mention even briefly who might be able to do that?
The comprehensive medication review is a pharmacy service that's offered to patients if you're billing it to Medicare Part D. So only pharmacists are allowed to bill Medicare Part D for a comprehensive medication review. However, it's worth doing a comprehensive medication review, whether it's a billable service or not, right? Because it's going to identify some issues that your patient is going to benefit from.
Sure. That makes sense. And I know that Dr. Schwartz already gave a brief answer in the Q&A, but it came up in the beginning too. So I want to use our last 2 minutes just to talk a little bit about when you're speaking to others on your team or providers on your team, again, the interprofessional approach, recommendations about how to discuss polypharmacy concerns with them, or it could also be from the patient perspective. So just would love any other final communication thoughts from both Andrea and Stephanie.
Thanks. It's such a good question. And, my approach is really one of curiosity and of giving the benefit of the doubt to the patient or the provider. We always want to assume people have the best intentions, and whether it's a lack of knowledge or a lack of resources to deal with a particular scenario. So I think just approaching with curiosity, sharing one's concerns, and if you have ideas about alternatives, bringing those together in a non-judgmental way. And I see Lisa's question about, how would you approach that with the prescriber? I think, again, as a prescriber, I'm always very grateful when someone brings a suggestion, because it takes a team and different perspectives. So I think approaching with curiosity, I notice the patient is on this med and I'm curious if, what the reason is for it. here's what I'm concerned about. Would you consider da 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 da? And recognizing that there's not always one right answer. So there are sometimes multiple reasonable approaches, but that we're all on a team and we're all trying to do the best for our patients.
I would
Absolutely.
agree with Dr. Schwartz if I may say it's a delicate balance because you do want to make sure that I mean, in our profession, you're respecting the decisions of the clinical provider or the clinician in the patient's care, but you also get a more holistic, sometimes a holistic view of what your patient is actually taking. Quite frankly, patients are not telling the clinicians all the time what they're doing, but they'll come in the pharmacy and they'll tell the pharmacist what they're doing. And so it's really just a matter of making sure that you are trying to include the clinician on those conversations that the patient may or may not have had with the clinician, and vice versa, that the clinician is sharing that conversation they may have had with the patient, so that we're all working together collaboratively to improve the patient's care.
Wonderful. Well, it's one of those sessions where I wish we had even more time because there's so much wonderful content and so many good questions, but we'll wrap it up today for now. But I want to thank so much Andrea and Stephanie for sharing all of their insights. The slides will have even more content. I know we had to skip over just a little bit just for the sake of time. We'd love for you to take just a moment as you exit to give us your feedback. We also hope that you'll join us for some future learning activities. And again, thank you to our wonderful panelists. Hope everyone has a fantastic rest of your day. Take good care.
Thank you.